Hello, everyone, and welcome to the ASCOT webinar. I'm Birgit Tokeschitz. I'm based at the WU Vienna University of Economics and Business, and I'm chairing this webinar today. I've conducted research for a couple of years, and I led the group that translated ASCOT into German. The webinar today is part of the anniversary webinar series. The series is celebrating 10 years of social care related quality of life impact measurement using ASCOT, so the Adult Social Care Outcomes Toolkit. ASCOT, as you all know, was originally developed in England and has now been translated into 9 languages, comprising languages spoken in Europe, such as Finnish, German, Danish, Dutch, Norwegian, Swedish, Spanish, and in Asia, such as Japanese and most recently Chinese. It's quite impressive, so how this toolkit has developed. And today the webinar will give you some insights into such translations and cultural adaptations of ASCOT into other languages and settings. To be more specific, we will travel up to the north to learn more about the experiences in translating and using ASCOT in the Norwegian context. And for this talk, I'm very happy to welcome from Norway, Maren Sogstad and Ingeborg Skjertner from the Center of Care Research in Gjøvik, Norway. For the second presentation, we will travel a lot of kilometers to the south, 3,500 kilometers to the south, to Coruña in Spain. So I just looked it up in Google Maps, and for those interested, it will take you 35 hours to travel by car. And if you would like to travel by public transport, it will be about 2 days by public transport. And for those who like to walk from north to south, from Norway to Spain, it will take you 26 days walking. And the reason I'm saying this is because distance may have an impact on how what people think, what people's well-being is. And we don't have to worry about the distance today because modern information and communication technologies make it easier to meet. So for the second talk, I'm very happy to welcome from Spain, Dr. Bruno Gasal from the Department of Applied Economics at the University of A Coruña. And Bruno will share with us his experiences in translating and adapting the ASCOT self-completion questionnaire to the Spanish context. And for this webinar, the setting is each presenter has sort of 20 minutes, and then we have 5 to 10 minutes for questions. And to the audience, please feel free to add your questions and comments to the chat at any time you want to, and we will discuss this after the talk. Now I hand over to Maren for the Norwegian ASCOT experiences.
Perfect. Thank you very much, Birgit. I tried to share my screen, and that's always a bit hard to find the right one. No, it's absolutely not there.
If you hover your mouse at the bottom of your screen, it should pop up as a ribbon with a green share screen button.
Yeah, it's there, but I can't find the right window. That's always a bit of a... Why isn't it there? Try again. Sorry for this. Do I share anything now? Not yet.
Not yet.
No.
Not yet.
Not yet. Still not yet.
Yes.
Perfect. And then I'll try to do in a presenter view. Is it
perfect?
Yeah. Oh, yeah. Thank you. Sorry for a bit late start. I want to just talk you through a bit of the Norwegian ASCOT project, which we are called Impact and Outcome in Long-Term Care, introducing a measure of care-related quality of life. And then Ingeborg will tell a bit more about our translation process. So just to kind of set the context, Norway is one of the Nordic model countries. So we have quite high taxes that pay for different public services among both health and social care. And the Norwegian healthcare system is kind of divided in two. It looks very divided. It's not this divided, but just to kind of see. And on the kind of top, we have the hospital, which is run by 4 hospital trusts that are responsible for providing hospital services. And they got financing from the government. And at the bottom, we have the local level, which in Norway called municipal health and care services, which are responsible for all other kind of health and social care. And that means if you as a person have any needs, you can put your needs forward and they are obligated to provide you with the care you need, both healthcare and social care needs. And they also get funding from the government, but the municipalities has to do a lot of different tasks. So they have to do the priority setting between like schools, infrastructure, health. So they have a much more broad priority setting obligation. In Norway, as everywhere else, we're getting older and older. And in 2025, we expect to be more elderly than younger persons. And that obviously put a pressure on the healthcare system like everywhere else. We are kind of in a good position, and we have, like, if you look into the workforce in long-term care, we are quite high up. And also, if you look into the number of care workers per 100 person over 65 years of age, we are quite well staffed. But even though we experience a lot of problems, just today we had this governmental working group that's published a report on workforce for the coming years. So we all have the same problem as everybody else, and that's kind of relevant for the use of the ASCOT. We mainly focus on the municipal level, which consists of home care, both nursing and practical social help, and nursing home, which are both long-term stays in nursing home, and we also have quite a lot of short-term stays that's more for rehabilitation purposes for people going back home. You can kind of present the services in a kind of a care ladder where you kind of start off without any needs and without any services. And then we have the first step, that is prevention and early intervention. You get home help, home nursing, residential care, which is kind of like a facilitated living arrangement, and finally stays at nursing homes. Traditionally in Norway, the municipal health and care services had a generalist approach. They did everything, and it was kind of the same persons going around doing every different task. But eventually, given more and more advanced tasks that have been pushed down from hospitals down to the local settings, the services tend to be more and more specialized, both regarding for different patient groups, but also for different kind of competencies, which give it a more like a specialist approach today. And why did we find ASCOT a relevant tool in this context? As we see, more and more both responsibilities and tasks kind of pushed down from hospitals to the local settings, and the pressure on the services going up, we see that medical needs are kind of have the highest priorities, giving less priority to more care-related needs. So we thought that in this context, it would be very relevant to have kind of ASCOT as a tool to kind of follow the development also from now and further on, to see how does this really influence on the quality of life for persons receiving these kind of services. And also we have an ongoing reform. It's kind of a bit in a shift due to a government change, but we have this reform called Live All of Your Life, or Live for the Full of Life, which was kind of branded like a quality reform for the elderly that put focus on these more social care needs, activities, social settings and things like that, food, and all the kind of main areas of ASCOT. So that made it really relevant in the Norwegian context just now. And also for the future in Norway, like everywhere else, there are some trends and policies that are put forward. First of all, it's more use of technology, but also more co-production of services where like volunteers, family, other actors are increasingly contributing, and also a more focus on prevention and active aging, which puts more responsibility on the individual itself. And together, this co-production and preventive and active aging kind of lead to new and distributed care among different actors. And in this context as well, we see ASCOT as a very valuable tool to follow how this change in services and organizing of the service influence on care-related quality of life. So this is our project. We have finished the first work package, which was the translation process and adaptation, and we're currently doing interviews. We decided to do all interviews because we're just including elderly care receivers. So we're doing interviews in a home care setting, in sheltered housing, and in nursing homes. So I'll tell you a few experience from that afterwards, but first I will give the word to Ingeborg, who will say a bit more about the translation process.
Okay, I'm going to give a short presentation of the translating and so far testing of for Norway. My name is Ingeborg Strømsteng-Skjetne. I work at the Norwegian Institute of Public Health in the Division for Health Services. And I am involved in this research due to the expertise in the group I work with, which is we use survey methodology to measure patient-reported outcomes, patient-reported experiences, and we also do a few personal surveys. Most of it has been in specialized healthcare so far, but these days the municipal health service is getting more attention than before. My background, in addition to a PhD in health services research, is that I am a registered nurse, and I've been working in nursing homes for 10 years earlier. So I feel strongly loyal to the patients and the workers in the homes, to practice, to say it short. So for the task at hand, I have borrowed the figure from the guidance for translations of ASCOT. I find it a good structure to follow when I am going to report of what we have done and things we have experienced. And of course, this series of stages is not taken out of the open air. It's referred to in scientific publications and everything. So standard process. The first steps I was not involved in, but the first was that INT4 was reviewed for target country, where the aim was to catch any terminology or concept specific to the UK that could not be directly translated, and to establish alternatives that will be applicable to the social care provision in the target country. So in Norway, social care services or practical assistance are more or less fully integrated with home health care delivered by registered nurses or licensed practical nurses, and when needed, physiotherapists or occupational therapists. So this means that it's not one-to-one comparable to what social care is in the UK, the way I understand it. So a potential user is assessed by the municipality, and a so-called decision or vedtak is made about what services the user is entitled to, and the services will be delivered as specified in the vedtak or decision. And the service user can choose to receive services with some co-payment from the municipality or from a private provider. Could be for profit or not for profit. So we are aiming to get the users' descriptions of any services that is paid by the municipality, no matter whether they are performed by municipality or other providers. So this was the third step, the third stage. And I wasn't quite sure of who I was to talk to today. So perhaps this is too elementary for some of you, or maybe not. I hope you bear over with it.
Sorry to interrupt, Ingeborg. I just wanted to know, are you moving your slides forwards? Because we're still only seeing your first slide.
Okay. Oh, okay. Is this a log off and log on situation?
I wonder whether it's worth sending your slides to Lizzie, and she could share the screen for you, maybe.
Yeah. And Lizzie was the one.
We've now moved on. I don't know what you did. We're now looking at the slide that says review for target country.
Okay, so you now have my old screen. Okay, if this works, it's okay.
Yeah, brilliant. Thank you. Sorry to interrupt.
Oh, it's okay. It would be worse if you had said it in the end. Okay, so I was speaking about not being too sure about who I'm talking to. So perhaps this is all trivial to many of you, but I think the worst thing would be to speak to people who doesn't follow at all. Okay. So did it change?
Yes.
Yeah. So the translation process in itself was done by a translation company with 2 independent forward translations from English to colloquial Norwegian, and with a subsequent reconciliation, and then 2 independent backward translations from Norwegian to English with subsequent reconciliation. And as you see from my illustration below, it's we belong to the same language group, and the way I understand it, we are reasonably comparable when it comes to culture as well, in England, Norway, UK. The next step I was involved in was in-country review to assess if there were any problematic items, suggest alternatives with the rationale, and also a professional review to assess the appropriateness for use in the context. If the in-country team possessed expertise in the social care context in the target country, then the professional review can be omitted. So on the left picture, you see parts of the in-country team, and altogether the majority of the in-country team are nurses with some experience in nursing homes or home care. So we thought we were also a professional team able to do the in-country review. And we had good support from the different tables and the structuring tables that was included in the process. This is an example where we can follow from the left column the original text, the harmonized back translation, the in-country team's reconciled translation, and then the reasons given for suggesting such changes. So there are some challenges in, for example, words. The word prompt, we don't have anything like it in Norwegian, so we just used another word that we thought conveyed the meaning of it. Comfort we have in Norway with a slightly different connotations. Comfort will be more like things you experience in a spa or very good sitting chair or something. dignity was also challenging because the direct one-to-one translation would be värdighet, but it would be quite rude to ask people if they feel that their dignity is harmed the way it works in Norwegian. The word want may have two connotations in English, as far as I know. It may be something that you're missing, that is lacking, or it might be something that you wish to have. Adequate we have in Norwegian. You could translate it one-to-one, but it's absolutely not a colloquial Norwegian. So we had a lot of discussions and found in all cases the solution that we think is okay, perhaps not optimal, but okay. We also had some comments on whether the translations had the correct contents. We had some comments on the grammars of the harmonized translation, so we suggested to be corrected. And we also had some questions about the clarity of questions. I have the next slide. I had an example for a difficulty where it's about the response options, about the questions about food and drink, where the optimal response options was in English, I get all the food and drink I like when I want. And we translated it to about one-to-one translation of the English version, but when comparing to the German, in German, it's what food is preferred has a larger place in the statement. So in this case, we chose to stay as close to the English original as possible, but it's a little red flag here when it comes to making international comparisons. It is necessary to have that in the back of the mind. It is also an example of one question really describing three different phenomena. It's about what you prefer, how much, and at what time. So the solution was to keep it as simple as possible for the informants in the end. So the next stage included pilot testing, also called cognitive debriefing, where the respondents are being interviewed and asked to comment on response options and any wording that was difficult to understand and suggest alternative wording. Then respondents should also be asked to describe in their own words what the wording meant to them. So it's a rather difficult task. And when we reached that stage, it was a pandemic hit. So that was quite harmful to the process, because during the pandemic, contact with elderly persons was strongly advised against. So we started off with doing FaceTime interviews with 6 informants. 2 of those were real users and with relatively limited needs. 4 were carers or next of kin to users with comprehensive needs. And then additional interviews were conducted when the restrictions were lifted. It was possible to do face-to-face interviews with the users in sheltered housing, with 3 elderly women and 1 old married couple. And results of the pilot testing was in general that where there are opportunities to shorten or simplify the questionnaires, such changes should be made. An example of what we did was a response option was, I'm able to spend my time as I want, doing things I value or enjoy, was replaced with doing things I like, for the sake of shortening it. We also discussed with the developers and left out each topic had 3 questions. What is the situation today? Does the services mean anything, or does the services affect your situation? And if the answer to that was yes, then the third question, what would it be without the services? So the middle question was omitted because the effect on daily life would be shown through comparing today's situation with the hypothetical situation if they had no services. And this was done. Everything was done in order to simplify it, because the informants in the pilot testing was users in a rather good condition, but when we were going to use it or altogether, it would be used to very frail informants. So keeping it short and simple was an important objective. So far we have studied the questionnaires' ability to communicate with the target group on an individual level, and the ongoing large-scale data collection may confirm the usefulness of the Infor or may indicate that further development is needed for it to produce valid data about the services under observation, because the way I see it, it's the service, it's not to be used on an individual level. So we look forward to the next chapter. I have some comments on the process. I think it was well prepared to handle differences between the services in different countries, doing the client review, localization changes needed. Process was well facilitated with the detailed descriptions of each stage. This was good support for understanding and communication about the process between the parts being involved, and there was rather many parts. And also that they had detailed explanations to help clarify the phenomena in question. So in light of the process in Norway, I have been thinking about the usefulness of the forward-backward translation in general, and if the backward translation would be more useful if placed at the end of the process to ensure concept equivalence after the modifications, as we did some small and some a bit bigger changes underway, and perhaps we should take, fulfill the circle and go back to compare it to where we started in English. Yes, that was my final slide.
Okay, first of all, I would like to thank the ASCOT team for inviting me to participate in this seminar. I'm going to explain what we did in adapting the ASCOT SCT4, but it should be mentioned that it's not the best of the only strategy that can be used. Among other factors, the strategy depends mainly on the experience of the team, the type of questionnaire, and this. Okay, this is the basic structure of my presentation. I want to share with you some basic principles of the cognitive debriefing interviews. Then I'm going to come into the Spanish experience and the main results in adapting the questionnaire. So two slides to present the next steps in validating the instruments. As you know, creating a survey with evidence of reliability and validity can be difficult for so many aspects. The intrinsic, the personal, mental processing of survey items and the social context may influence how well questions capture the real situation of the respondent. And it's worth considering that the interpretation of an item can be culturally specific or vary across countries or contexts. For this reason, it's necessary to revisit whether the question can be asked in the same form across all of these contexts, looking for some understanding, for the same understanding of the text of the questionnaire. So the main objective of cognitive debriefing interview is to evaluate this understanding, is to evaluate the presence of some errors in the questionnaires and whether the question fulfills its intended purpose, okay? So this is the main objective. So in other words, the main goal is to prompt the subject to reveal information that provides clues to reformulate the questionnaire and to improve its understanding. So this is important. We have to think that we are not going to carry out the survey. The main aim of the interviews is to assess the understanding of the questionnaire, not to carry out the specific survey. Another question to take into account is that the participants must have the specific characteristics. In our case, the ASCOT SCT4 is to present a dependency state and also to receive formal care, okay, to this. Our experience is related to this flow chart. So this flow chart shows the stages for testing the questionnaire. And I have to highlight a key stage in this flow chart, that is where the questionnaire needs to be retesting. Lizzie, as you know, and Anne and Marie, we have to retest our questionnaire for different problems in some understandings, okay? Our experience, the process comprises 4 sequential phases in our experience. So in the first stage, is dedicated to ask the subject about the question intention and the meaning of some keywords and phrases. So what he or she understood. In the second stage, we identify other options to ask the same item and words or phrases difficult to understand. In the third stage, if the interview did not understand the intention of the question is explained by the interviewer, then the subject asks again about reformulating the question. And it's very important to dedicate time to the 4th step. So in the 4th step, we verify the match between the subject's answers and the response options. It's a very important stage in the process of validating the questionnaire. So this process that I have explained is reflected in the template used in the interview. So these numbers show at the same time these 4 stages that we develop in validating our questionnaire. So sorry, this template is in Spanish, but it's the same as I show you in this slide, okay? So we transcribe the interviews following this stage into this template, okay? The method, we choose the think aloud method to carry out the interviews. So following this method, subjects are invited to think aloud as they're answering the question. So they show the process of understanding the question and explain their thoughts as they attempt to answer the questions. So the main role of the interviewer in this method is to ask the subject to keep talking. For example, tell me what you understand with the phrase. Please tell me about how you arrive at your answer. Do you know alternative words instead of what does this term mean in your own words, etc. So keep talking, the interviewee. And in this sense, if several subjects need help in order to explain the intent of some questions or the intent of some responses, or is unsure with his or her response, there is a comprehension problem. So this method, we choose this method because of the following advantages. So from our point of view, there is, using this method, it's little intervention of the interviewer. So this means little interviewer bias to the subject's responses. From the point of view of the team, there is, using this method, is a minimal interviewer training requirements from our point of view. It's a method that provides more information to reformulate the questionnaire than other type of methods. And the last advantage of this method is that literature state that it's a good method for short interviews. Long interviews make excessive demand on subjects and tend to spend a significant amount of time in explaining the understanding of each question and in explaining the understanding of each response option. Talking about the sample, this is the controversial, always is a controversial topic. How many interviews? I think that we know that the perfect questionnaire does not exist. So a questionnaire could be tested forever and still have problems. So for our point of view, we believe that it's not necessary large samples to evaluate the understanding of a questionnaire. So there is not set a number of how many interviews are required to adapt the instrument. We think that the larger the sample, the higher risk of saturation. So the more options to interpret and to reward a question, the more distortion you will have. This is our interpretation of the sample size. Okay, so I think that also it's a developer decision. It's also a developer decision, and we follow the developer decision about the sample size in validating this ASCOT. The encounter team should consider that that the purpose of the cognitive debriefing is not any statistical information. The nature of the interviews is qualitative, not quantitative. And the objective of the interview is not collecting data, but rather testing a questionnaire that has questions that may be difficult to understand, that may be difficult to respond. So this is, sometimes we forget these goals in testing a questionnaire. And I want to share with you some recommendations and sometimes some obligations. So the first recommendation is to confirm that the participant qualifies for the study. So if he or she presents a cognitive impairment, it's very important. It's a key question. The second question is that the cognitive interviews must be conducted face-to-face to observe body language, to provide a more natural type of interchange, so avoid phone or online service. I think that the role of the interviewer is to help participants to feel comfortable. So use an icebreaker questions to help relax the participant, eye contact, conversation about his or her good memories. It's a very good way to link people in order to dedicate, in our case, 45 minutes to this cognitive debriefing interviews. And we should try to avoid some common mistakes, for example, using a key term because you are conditioning his or her understanding, not obtaining verbal confirmation, discussing his dependency situation without a time frame. So for these common mistakes, sometimes a new round of interviews, a retest is needed if some problems are identified or to test the change made. So this was our case. I think that the retest was a very good decision that was agreed with the ASCOT teams. So this is a basic introduction about the cognitive debriefing interviews that I want to share with you. But in the next slides, I'm going to explain briefly our experience on subject recruitment, about analyzing the subject responses and the main results of our interviews. So we use a convenience sample of dependent people. These dependent people fitted the characteristic of interest, so dependent population who receive formal care. And we contact social workers to recruit and to enlist the potential subjects. They also participate in the cognitive debriefing interviews. And I'm going to explain why. We decided to make the social workers participant in order to create a friendly atmosphere, because the interviewee does not know us before. So this second person helps to create this friendly atmosphere. Another questions that we take into account is that we know that volunteers for cognitive debriefing interviews are by definition self-selected for participation. So we should not forget that they are not representative of the survey population as a whole. So these volunteers tends to be higher in level of education than the average survey respondent. So this should be considered in evaluating the level of understanding of each questions. So for example, in our case, the word self-esteem was a word that was only interpreted correctly by those people with higher level of education. So we have to change our recommendation to reward this the dignity question. I'm going to explain this after some slides. Okay, we interviewed 5 older adults living at home and receiving formal care from social care services of a Spanish council. These interviews took place at the home of the participants between April and May 2022. The participants were chosen according to the following inclusion criteria. So they gave the informed consent, they had not a cognitive impairment, present officially recognize a level of dependency, require help from social care services, and then the inclusion criteria related to education, to gender, and to age, and also people whose native and usual language is Spanish, because we live in a region in Spain that is Galicia, and we have our own language that is spoken only in this region. So we have to choose only those people that speak Spanish. It was very important for us. As I explained before, a new round of interviews was needed because some problems were detected in the intention of 2 domains: control over daily life and dignity, questions 8 and 9. So this retest was carried out with new dependent people. We believe that new interviews reduce the bias of the first interview that the first interview could introduce in their interpretation. So we look for new dependent people. Interviews took place at a daily care center in August 2022, and we applied the same inclusion criteria as in the first cognitive debriefing. So this table gathers the main characteristics of the interviewees. In analyzing the subject responses, it's very important to follow at all times the concept elaboration guide. It's also an added value to count with the help of a native bilingual. Native bilingual in our case is Spanish and English, who can help to interpret the language not only literally, but socially. In our case, Belén Couce, a girl who grew up in London, was fantastic in all of this process because she is a native bilingual in both languages and helps to reward some phrases and to explain some phrases for some of this interview. So all of these results were transcribed to an individual report, and we identified problems as conceptual, for example, a function of the original English, linguistic, a function of the words used in the translate the English concept, or stylistic, for example, a function of the subject's preference for a different wording. All of these notes were combined, seeking common interpretations, identifying key findings in order to reformulate questions and response options, and then we produced a final written report. All of these results were discussed with the developer to determine whether changes in the translations were needed, okay? Nevertheless, in every moment, we try to preserve the integrity of the original translation. So each item was assessed individually, and the translations was changed only if significant comprehension problems or linguistic concerns were noted among the sample. So we try to preserve the integrity of the original translations. Okay, the results. So in general, we have to say that almost all the questions and the response options were understood as intended. The domains, control over daily life and dignity are the items that presented the major revisions. And the other minor revisions were also needed for food and drink domain, social participation and involvement, and occupation, and not any kind of change in the domains of personal cleanliness and comfort, personal safety, and accommodation cleanliness and comfort. In the domain control over daily life, some of the interviews understand the question in the sense of physical capability of doing things by themselves, more than the capacity to make decisions. And the difficulty was focused on the word control. When the interviews were asked for an alternative, they proposed the word organize or the word make decisions. So the developer suggested testing again, including choice and control, and include reference to organization and making decisions in the prompt. These were the main proposals from the point of view of the developer. So the main changes done were to introduce in the question and in the response options the word decision, and to introduce in the prompt the phrase having the choice to organize things. The retest, the second cognitive debriefing interview, confirms a good understanding of these changes. Regarding food and drink, some interviews present some doubts about starting level 1 in the response options, because the diet, they said literally, the diet does not permit me to eat and drink what I like. So they refers to the diet every time. Yes, it should be mentioned that the verb like in Spanish has the interpretation of personal taste. This was the main problem in this question. And the ASCOT guidelines state that this question intends to capture if he or she has a nutritious, varied, and culturally appropriate diet with enough food and drink he or she enjoys at regular and timely intervals. So to introduce the idea of having enough food in terms of both quantity and quality, the word adequate, in Spanish, adecuado, was introduced for this. In social participation dimension, the contestants had clarified to some interviewees the concept of socially isolated, the level 4 in the response options. The interviews stated that the expression to feel alone has a better in understanding, sentirse solo in Spanish. And this suggestion was accepted by the developer. Regarding time occupation, minor changes were done only in the expressions of the prompt, formal employment and unpaid work, because in Spanish, the word employment is identified always as a paid job. And the word formal is not necessary to understand this idea in Spanish. So we decided to delay these two words. Also in the response options, to capture the capacity of people in doing things, we also propose to change the expression, I'm able to spend my time, for the expression, and spend my time. Capture this capacity of people in doing things. And dignity filter questions. And the dignity question. So interviewers really did not understand the question or understood it partially. Only those people with a higher level of education had understood this question. And when the interviewers paraphrased the question, interviewees suggested more colloquial Spanish terms, such as being upset, feel uncomfortable, feeling less value, or the word self-esteem. It was a crazy word for us, self-esteem. Our first alternative, the first alternative that we proposed to ASCOT team was to introduce the word self-esteem in the response options. But the retest has confirmed the existence of an important comprehension problem in the word self-esteem. Only those people with high level of education understood this word. The word feelings, sentimientos, in Spanish was introduced during the interviews by some interviewees. And both teams believe that it achieved the intention of the original English question. It must be taken into account that this is a filtered question, which main objective is to focus interviewees in the dimension number 9, the dignity question. So we decided to include feelings in the question, in Spanish, sentimientos. No doubt, this was the question that created more problems during the interviews, being a source of a long and a deep discussion between the Spanish and the ASCOT teams. Interviewees did not understand the translate question or they wrongly paraphrase it. Particularly, they did not understand the expression to think and feel about yourself. When the intention of the question was explained, they paraphrased expressions such as feel respected, feel value, feel comfortable. Then we propose to include expressions feel respected and feel value. ASCOT team then suggested that in any case, the same words as in the dignity filter question should be introduced. In this case, remember, feelings and self-esteem. And then the questions must be retested. As in the dignity question, filter question, the word self-esteem was not considered. The word feelings achieved the objective of focusing the interviewee in his or her feelings, but it's not valid for these questions. Feelings is understood under different perspectives. For example, being well, feel comfortable, being ashamed, and incorporates intrinsic aspects of the person, not related with the care he or she is receiving. In the interviews, some interviewees had paraphrased words such as respected, value, and we believe that these words gather perfectly the influence of the care on the person's dignity. The only change we include this, and also to differentiate question 9 and question 8, we suggested ASCOT teams to introduce in the questions a short sentence. This short sentence: now think of the way you are helped and cared for. And both changes, to include respected and value and to include these short sentences, were accepted by the ASCOT team. Okay, these are the main results of our interviews, and then 2 minutes to explain the next steps that we are taking. And the first step is validating the instrument. For validating the instrument, a convenient sample of 300 people receiving long-term home care is used to test the validity. All of these 300 people have some degree of dependency and receive formal assistance for the performance of some of their activities of daily living. And in the questionnaires, in the interviews, in addition to the socioeconomic characteristics and the Spanish ASCOT, of course, we gather information on health-related quality of life. We use the EQ5D, the self-perceived quality of life, the DEP 6D index. This is an index that we design. And this index evaluates both the performance of activities of daily living and the level of dependency. Lawton and Brody Index, Barthel Index, and the validity of the Spanish ASCOT will be established by testing the associations between the Spanish ASCOT scores and this type of scales or measures. And the last step is to obtaining the weights. These weights will be estimated on the preferences of the Spanish population. We are going to use a sample size of 1,000 people representative of the Spanish population by age, gender, region, rural, urban area, educational level, socioeconomic level, and this will be interviewed. These people will be interviewed during the end of 2023, and we are going to use two methods of preferences elicitation. The first one is a variation of the best worst method and the time trade-off method. The former is applied in order to transform these weights into a quality adjusted life years.